Assalamu alaikum rahmatullahi wa barakatuh. We welcome you all in our breast cancer webinar. I'm Jude Asfari, level 3 medical student, a member of MMSC. At first, I would like to briefly introduce the MMSC, ALMAAREFA Medical Student Committee. We are a group of medical students from different levels, from both the males and females campus. Working under the umbrella of the College of Medicine at ALMAAREFA University. Our main goal is to enhance and enrich our academic journey with webinars, research projects, and much more to come. We would like to thank Prof. Abdel Jabbar, the Dean of the College of Medicine, Dr. Asiri, the Vice Dean, and Dr. Sharbini, the Supervisor of the MMSC, for their continuous support and efforts. Now I will leave you with Ruba Alturki, level 7 student and member of MMSC, to start our webinar. Now I will mute all, and sorry for that, and we will be taking any questions and discussions at the end of our webinar, last 15 minutes. Thank you.
Assalamu alaikum, everybody. My name is Ruba Alturki. Thank you, Jude, for the introduction. I'm a level 7 student, and today I will be presenting breast diseases webinar. So right now we're in a month that raises awareness for breast cancer, although we are at the end, but it's never late to raise an awareness. And I want to shed light on the basic knowledge of diagnosing a breast cancer patient, either your family members or people around you. So today we will be discussing the benign diseases, benign tumors, and more deeply in the breast cancer. We're going to see the types, we're going to see the risk factors, clinical presentation, the history of your patient, what investigation we will use, and how to manage it. So what is the importance of breast diseases and why do we need to know it? It's been shown that 25% of surgical referrals have been for breast diseases, and studies show that 1 in 4 women at some point in their life are referred to a breast clinic. So it's shown that breast cancer is like one of the top 10 causes of death in Saudi Arabia, and it has a 21.8 prevalence. So it's obviously very dangerous, and we have to be aware of it and try to diagnose it before it goes and progresses. So we will start with the benign diseases. We have a benign disorders and benign tumor. For the benign disorders, we have the breast infection, which is very common. You can see an abscess. And we have disorder of cyclic changes. You're going to see a persistent follicular nodularity, and we have to exclude breast cancer by full investigation. We have cysts. We can confirm it with an ultrasound. We have ductectasia and gynecomastia. Gynecomastia, you usually see it in men. It's when the estrogen is higher than the androgen, and we can see it also in hypogonadism. Oh, excuse me. Okay, over here on the right, we have a picture of an abscess. You can see the skin, it's shiny, and it's kind of red with some edema. Over here, we have an ultrasound of multiple cysts. You can see there's dense fibrosis. Now, let's talk about the benign tumors. We have fibroadenoma. Well, fibroadenoma is quite common, and especially at premenopause, at 15 to 25, and it's well circumscribed, and it's mobile, and it's smooth, and it's firm. And we also we can see it in the upper outer quadrants of the breast, and we diagnose it by a core biopsy. How do we manage it, you might ask? Is we use if the mass is less than 4 centimeters, we reassure your patient and do a follow-up just in case the mass increases in size. If it's more than 4 centimeters, you have to do an excision. Over here in the picture, You can see that it has a smooth outline and it has a thick capsule. It can be bilateral and it can come in multiple masses. For duct papilloma, your patient is going to complain of blood discharge from their nipple. So you're going to have to treat it with a duct excision, microdectomy. Over here is a diagram that shows how it's seen. Over here you can see there is a mammary duct. It's dilated, and around it is a large papilloma. Also, when you examine your patient, just by compressing the nipple, you can there will be some brownish, bloody nipple discharge, and when you palpate it, around it you can feel a mass. Okay, let's talk about the phyllodes tumor. Well, it's a very large bossulated mass. It consists of a fibroepithelial tumor, and it's not attached to the skin. Usually it's benign, it's usually benign, but if it's malignant and it metastasizes, it goes through the blood. We treat it, if it's kind of small and manageable, we do a local excision. And if it's very large, we would do a mastectomy. You can see over here, it usually has a thick capsule and dense fibrosis inside. For lipoma, it's just a soft lobulated lesion, so it doesn't usually it's not usually malignant. But if it's malignant, we can manage it in the malignant diseases. For that's for the benign diseases. Now we will be talking about the malignant diseases. So as in for breast cancer, well, it's very known that breast cancer is a very common and aggressive type of cancer. And usually you see it post-menopause. And we have a very important prognostic factor is when it metastasizes in the axilla. So when you see that, it's very important to note that. You can see it usually in the upper outer quadrant of the breast. So let's discuss the types. We have the usual malignant tumors. Either it can be non-invasive, invasive, or in pregnancy. And the unusual malignant tumors are the malignant phyllodes and malignant lymphoma, which we mentioned before in the benign tumors. So let's discuss the non-invasive breast cancer. So the cancer cells, they arise from the epithelial lining of the terminal duct or lobule, and they usually they're not invasive, so they don't invade the basement membrane. They're in the borders. So we have three types: the ductal carcinoma, which is very common. You can see microcalcification in a mammogram, and then we have the lobular carcinoma. So if you see a lobular carcinoma, just know that it's a marker of increased risk of future invasive cancer. So it can turn out to be invasive. And then for Paget disease, it's really known for nipple ulceration, and it's usually considered as like an underlying invasive ductal carcinoma. And also when you examine the breast, let's see here a picture, okay? Let's see. Here is the Paget disease. You can see an ulceration. It's affecting the axilla. When you examine, there could be an underlying mass, and your patient usually comes very late in stage. Over here, we can see that the nipple over here and here are the nipple retracted. Here's a normal nipple, and here's a retracted nipple. This is seen in carcinoma. Here's a diagram that shows the invasive and localized lobular carcinoma. You can see that here it's within the borders of the lobule, where over here it's invading other structures in the basement membrane. So let's discuss the invasive carcinomas, the breast cancers. So we have the invasive ductal carcinoma, which is also very common, around like 80% of invasive carcinomas. And it's very special because it has a very variable histological pattern. You can see tubular, cribriform, papillary, messiness, and they have a better prognosis. As in invasive lobular carcinoma, it's really rare. It's like you can see it can like 5 to 10% of invasive cancers. It can be bilateral, multicentral, multifocal, and your patient usually comes really late. Yani, you can't really detect it in a mammogram, and then when they come, there's a large mass. And when it metastasizes, it goes to the membranous structures like the pleura, peritoneum, meninges, and it's asymptomatic. That's why your patient comes really late. They don't notice it. But if it's symptomatic, your patient is going to come with a painless, ill-defined pudendal lump. There can be some nipple retraction or discharge. There can be a mass in the axilla, and there can be some skin retraction. As in the inflammatory breast cancer, well, this has a very poor prognosis, but thankfully it's only 1%. We don't see a lot. It has poor prognosis because it's rapidly progressive, and it's characterized by pain, arrhythmia, pudendal, and the breast is diffusely enlarged because the cancer cells, they disseminate through the lymphatics. And lastly, we have the medullary carcinoma with good prognosis. Let's take a look at the pictures. Over here, we can see that this is an inflammatory breast cancer carcinoma. You can see how it's affecting the external of the breast. And over here, we have a histological picture of the infiltrating ductal carcinoma. Here in this diagram, we have 3 types of ducts. You can see a normal duct where the cells are normal and they're arranged. There's no overgrowth. While over here, there's overgrowth, but it doesn't exceed the border or the basement membrane. As in an invasive, no, it invades the other structures. Also here, you can compare between the ductal carcinoma and lobular carcinoma. You can see that the ductal is less affected than the lobular. Okay. So if your patient comes with breast cancer and pregnancy, you really don't see this a lot. It's around like 1 to 2%. And your patient is going to come late also. This is why we raise awareness, because most of the cases, the patients come late because they don't notice it, or they kind of like ignore it. So here, especially in pregnancy, they come late because they think that just with pregnancy, their breast is going to change normally, and that's going to make it more aggressive, and which is very dangerous. So how are we going to manage it? If your patient comes in the 1st and 2nd trimester, we're going to have to do a mastectomy right after delivery, and we can give chemotherapy, but that's going to be a small risk on the patient, not the patient, on the fetus. As in for the 3rd trimester, we're going to do surgery and deliver like a premature neonate, and then we follow up with treatment of the breast cancer. Right. Now we finished the types. Let's talk about the risk factors. Gender plays a major role. Females more than no, it doesn't play a major role. It does actually. I'm sorry. Okay. So gender, females, and the age. The older the person, the higher the risk. The menarche, if you have early menarche, late menopause, first pregnancy. If you're young, less than 20. It decreases the risk. If you're old, 40, not you, your patient. If your patient is old, 40, over, like he has their first pregnancy over his 40, that increases the risk. Breastfeeding in long duration, hormone replacement therapy, obesity, exposure to radiation, their diet that's high in saturation, saturated fat, and genetic factor. Genetic factor plays a major role here. Yeah. Now let's see the spread of breast cancer. It can spread through direct spread, like the skin, the muscle, the chest wall, the pleura, or lymphatic spread through different lymph nodes, like the axillary, the internal memory, mediastinal, the supraclavicular lymph nodes. Those are all around the breast. And also, through lymphatic spread, it can go to the opposite breast. And it can go to the liver, or it can go to the peritoneum. And as in blood spread, we stage it as stage 4. It can go to the lung, the liver, the bone, and brain. All right, over here is the staging of the tumor. We see the tumor size. Did it spread to the lymph nodes? Did it metastasize to the other organs of the body? Yeah. So what do we do if there's metastasis in an advanced stage? Unfortunately, it has a very poor prognosis. Your patient's average survival might be like 20 to 30 months. What we do is like try to do an effective symptom control, and we try to limit the side effects. Although even if we try to treat the metastasis, it's not going to improve the survival. If there's any fungating lesions, we'll just do surgery and remove it. We'll try to do like the chemotherapy, hormone therapy, but it's not really effective at this stage. We finished with the malignant diseases. Let's now see the clinical area. So clinical presentations of your patients. So, here, what are you going to think of? So if your patient comes with a painless lump, you're going to think of carcinoma, fibroadenoma, fat necrosis, and cysts. If they have a painful lump, you're going to think of fibroadenosis or an abscess. If their breast itself hurts, you're going to think of fibroadenosis or just premenstrual pain. If the breast size change, you're going to think of giant fibroadenoma, phylloides tumor, and benign hypertrophy. Changes in the nipple, like if it's retracted, as we showed before, the carcinoma, a retracted nipple, or if it's ulcerated, Paget disease. And if there's any nipple discharge, you're going to see the color. If it's red, you're going to think of the ductal papilloma and carcinoma. If it's kind of yellowish green, you're going to think of ductectasia or fibrocystic disease. If it's white, milky discharge, you're going to think of bacteria. All right. So let's see how are you gonna examine your patient. So first of all, explain to your patient what you're gonna do. Tell them that you're gonna do an clinical examination. Tell them take their permission. Give them some privacy. You can have a nurse around to help you around. Okay. And then now, when the patient is settled and gave you permission, expose the upper half of the patient and make sure that both breasts are exposed. So you can compare, like if there's only one breast is affected, you can compare to the normal side. And then start taking a detailed history of the complaint. Ask your patient about the lump. When did they see it? Has it changed? Did it grow fast? When did they notice it? The lymph nodes, like for example, the axilla. Let your patient sit upright, and then over here you can see he's palpating the. Over here you can see him palpating the lymph node. What you do is you hold your patient's right elbow with your right hand, and then you palpate the axilla with your left hand, and then from the apex of the axilla, you press your fingers, and then palpate upwards immediately. And then for the left, this is for the right axilla. If you're going to do the left axilla, you do the reverse. Right? Wait, okay. That just, okay. For investigations, what type of investigations are you going to do? Okay, radiological evaluations. You're going to do an X-ray. You're going to do an ultrasound. Ultrasound, as we mentioned before, just to confirm if it's a cyst. A mammography, you're going to do a medial lateral oblique or craniocaudal. And then MRI. MRI are for patients that have a high risk of breast cancer, like their family members, like their mother, their aunts, they already have breast cancer. So we try to do that to patients. We try to use MRI to diagnose the breast cancer early because it's really sensitive. And then for the CT scan, we just use that for like the staging to see how what stage did the tumor reach. Over here, we have a mammography. Here we have 3 pictures. Over here is just a normal breast. Over here there's a benign cyst, and here we have a cancer. Right. Now the histological evaluation. We use fine needle aspiration, cytology. We use core biopsy. We also use open biopsy, And we have the sentinel lymph node biopsy. We use the sentinel lymph node biopsy. We inject isotope dye, so you can see, okay, the tumor, where did it spread to which lymph node, and then we can extract it. Over here, you can see that they injected a radioactive substance or a dye, and then they found which lymph node was affected, and then they removed it. And then lastly, we have the frozen section, which is not commonly used right now. Now, how are we going to manage the breast cancers? If you're going to manage the ductal carcinomas, you're going to think of the size. If it's less than 4 centimeters, you just do some local excisions. If it's larger, if it's larger than 4 centimeters, you're going to have to do a mastectomy. Usually, if it's like less than 4 centimeters, you try to do like radiotherapy after it, just to make sure that it doesn't go back again. And then for managing the invasive breast carcinoma, we can only operate on T1 to T3 and 0 and 1 and M0. So what we do is local therapy, where we can like do a breast conserving treatment. We just do like a wide local excision, or we can do a modified radical mastectomy. And as for the systematic therapy, we can do chemotherapy, hormone therapy with tamoxifen, aromatase inhibitors, ovarectomy, and anti-HER2 therapy. As it's been said, so right now they've been using a new treatment, monoclonal antibody. They use rituximab, cetuximab, and trastuzumab. Okay, excuse my pronunciation, but for the trastuzumab, they usually use this for breast cancer, right? Now for the new medications. All right, we finished with the clinical area, and we're basically done with the webinar. But I would like to end at a note. So as doctors, we are responsible to, like, whether we're preclinical students or clinical, we have to educate and raise awareness to our families or beloved ones and even friends in terms of self-examination. Here I'll explain how to do this self-examination, and you can teach the people around you. If you want to examine the breasts, raise your arm, let the patient raise their arm, and use their the tip of their fingers with some oil, and then go up and down the breast, and then go to the wedges, the edges, and then go in a circle motion, and then see in a mirror if there's any lumps or skin dimplings, and seeing if there's a color or change in texture, if there's nipple discharge, and if they say notice anything, they have to refer to their doctor as soon as possible. And yes, excuse me. All right. Thank you, everybody. I hope that you learned something today and to learn the basics of diagnosing a breast cancer patient. I would like to thank our dean, Professor Abdul Jabir, and Dr. Asiri, and I would like to thank Dr. Sherbini for allowing me the opportunity to give and present this webinar. And thank you.
Thank you, Ruba, for the great presented material. So anyone would like to ask a question or discuss a point, please feel free to do so. Okay. As the time has ended, I would like to thank you all one more time, our dear doctors and students, for attending. And thank you, Prof. Fan and Al-Madani and Dr. Shawqi for attending. This is just the beginning. We promise more to come, inshallah.
Any extra questions can be written on the chat, or if you'd like to open your mic. Thank you.
Assalamu alaikum. Do you hear me?
Yeah, everything is clear.
Yes.
Go ahead.
Thank you, Ruba, for this nice and comprehensive presentation. I have few comments. I know in your classification of the breast lesions, you mentioned gynecomastia. Gynecomastia is lesion of the male breast, enlargement of the male breast, as you know. This is number one. I wanted to highlight this point for the audience of your colleagues.
All right. Would you go back to it?
Sorry?
Would you like us to go back to it?
Yes, gynecomastia is enlargement of the male breast. Many reasons, many causes for this gynecomastia, either idiopathic or acquired cause, as you know. The second point, you mentioned that phylloid tumor, which is a breast lesion, may be benign, may be borderline, may be malignant. You described it as capsulated, surrounded by thick capsule, and characterized by fibrosis, which is not true. Phylloid tumor, non-capsulated lesion, very dangerous lesion. Also, you mentioned that frozen section not commonly used. Frozen section is very important technique now. The interaction between the surgeon and the pathologist is very important, especially in simple operations like lumpectomy or simple mastectomy. Also to assess the status of the margins of the tumor. Frozen section is a very, very important technique, widely used. However, the presentation is very nice, very comprehensive. I thank you very much. I suggest Dr. Sherbini, next time it's better to have one of or more than one of our colleagues to supervise the writing, to revise it, pathologists, surgeons, and because we want to deliver a very clear and accurate data to our students. Thank you again. Thank you very much.
Thank you, Dr. Abdullah. Yeah, that's really helpful.
Assalamu alaikum.
Walaikum salam. Go ahead. I'm sorry, who is it?
Me or not?
Yes, Prof. Alam, go ahead.
All right, Dr. Munir.
Yeah,
Good
go ahead.
afternoon. Yes.
Yeah.
First, I want to say it's a very nice presentation. Just a couple of areas I want to touch. First is that the majority of, I will just confine myself to carcinoma breast. The majority of carcinoma breasts are acquired effect of the environmental factor. The genetic or hereditary type of carcinomas are not very common. It usually accounts for about 5 to 10% of the carcinomas in general, carcinoma breast in general. The second point, I just wanted to mention that in the clinical assessment, we try to talk about the triple assessment. And these triple assessment comprises the history taking and the clinical examination as the first component. The second component is the diagnostics, where we use the mammogram and the core biopsy. It's preferred to use core biopsy rather than FNA, because FNA cannot tell you or cannot differentiate between non-infiltrating from infiltrating carcinoma. So if you have to do it, it's better to do a core biopsy. And if the lump is palpable, it can be done by palpation method. If the lump is not palpable, it can be done under the guidance of ultrasound. So once the diagnosis is made, then the disease is staged and the treatment is provided. And the treatment, Dr. Ruba has already described quite well. So there is very little to add. That the only point is that the majority of clinically presented carcinomas are present with a lump, and from that point we take on and we decide after the diagnosis the treatment plan. And she has already explained quite well the treatment plan, that the treatment up to T2 or T3 and N0, the treatment is local, where we can choose between the breast conservation, where we can save the patient's breast, or if the tumor mass is big or is larger than 4 centimeters, usually do modified radical mastectomy. And this is usually followed by the adjuvant therapy, initiated by chemotherapy, and in hormone-sensitive tumor by hormone therapy. And just want to explain that the use of these monoclonal antibodies is only recommended for if the patient's histology shows that the tumor has got HER2/neu growth factor within the tumor, then only you Herceptin or trastuzumab, these treatments tried. I think that was all about. Regarding frozen section, in clinical practice is not very commonly used these days, because all these, if you have evaluated your patient properly, preoperatively, most of the time the diagnosis is established and the patient goes to surgery with a full diagnosis at hand.
Yeah, true. That's what I thought. That's what I've heard.
Yeah, that's other. So, but it is a tool available to surgeons that in a difficult situation when the diagnosis has not been made, one can take help of it. So it is not so commonly used nowadays. Regarding what else was there? I think that was, it was very nicely presented with good pictures and good explanation. Congratulations to
Thank you, Doctor.
Dr. Ruba Alturki. Thank you.
Yes, thank you. Dr. Murray, I think you wanted to point something out.
Assalamu alaikum.
Hello, Dr. Nasreen. How are you? Go ahead.
How are you? Ruba, great work. I want to congratulate you on this work. And keep on, inshallah. I want just to ask about, if you talk about female breast self-examination as a preventive measure, early prevention or early detection.
Yes, that is the cause. This is the reason we raised awareness, to help our family members to learn how to self-examine themselves.
Yes.
To diagnose it.
Mammogram, is it recommended to do or not?
It is recommended to do. Not really a lot, because it has a lot of radiation, so we don't want to expose the patient to a lot of radiation. So if we can use different ways, but if we have, if we can't use any different investigation, we're going to have to use mammograms.
Can I just say a couple of words on it?
Yes, sir.
Regarding breast self-examination, it is recommended to train or teach patients, but its benefits are really limited. You know, that quite often it only increases the patient's worries.
Sure.
So it can be recommended, but patient has to be trained quite well to perform it well, because results are usually not very good, and many clinicians do not recommend it as a measure. But yes, it is there, one of the methods described or trying to educate patients. Regarding mammography, there are many countries where it is routinely recommended to be done after the age of 45, and some countries have got a slightly higher age recommendation, but it does. And in those areas around 10 to 15% of the cancers are detected by this method. So it's a useful screening tool.
All right. Thank you for noting that.
Dr. Al-Madani has a comment also.
Yes, thank you all. Thank you, Ruba. And if Prof. Alam is here, no fear, and I cannot add anything, Prof. Shukran, Dr. Abdulati as well. But a few comments and a few questions to you, Ruba. Does all painful lumps in the breast or painless lump on the breast means malignancy? So if the patient presented with a painful lump, would this exclude malignancy? What do you think?
I don't think it will exclude excluding malignancy right away. I don't think so, because sometimes the patient can have pain even from like menstrual cycles, or the lump is hurting some nerves. So you can't really think that it's excluded, correct?
So exactly. So painful or painless lump does not include or exclude malignancy. However, most of the lumps are painless, but it could be painful in advanced cancer. Now, how to confirm the diagnosis, whether this is cancer or not, is not really based on the history and examination. And sometimes the radiology is highly, give you like high suspicion lesion or something, but to confirm a diagnosis of malignancy is basically based on pathology. Ultrasound is done for somebody based on the triple assessment, as Prof. Alam said. The triple assessment means clinical imaging studies and pathology. So clinical is an important part of the diagnosis. Then we move to radiological imaging, which basically ultrasound is mandatory to do ultrasound. And if the patient is more than, as Prof. Alam said, if the patient is more than 40 or 45, we need to do mammography. However, sometimes we need mammography in patients below 40 years. But to confirm a diagnosis of cancer, you need to have a true cut biopsy or excisional biopsy to confirm the diagnosis of malignancy. This is the first thing. The second point, you have mentioned about risk factors, some risk factors for breast cancer. And you forget to highlight which is a protective risk factor. And on the other hand, what are factors that could raise the the risk of the cancer? So you mentioned breastfeeding. Breastfeeding is a protective factor for breast cancer. Also, multiparity, which is having more than one kid, is also a protective risk factor. And one more thing in regard of the management, you mentioned about fibroadenoma. You mentioned the only management and treatment is once it comes to the size. So once the size is 4 centimeters and above, you do excisional, excision or lump excision. But once it's below that, you don't do. Basically, there are many, I don't want to go into details at your, at the level of students, into details of how to manage fibroadenoma. However, once there is during your assessment, because a very characteristic of fibroadenoma is a very mobile lump in the breast, and usually patients are young age group. Now, even during clinical examination, you might, suspect something else, especially if during, you cannot diagnose based only on the history and examination, but you need to do ultrasound even for young age group. And by the way, mammography is having very low radiation. It's not the radiation that, because one of the misconceptions in the community that sometimes after they do the mammography and during follow-up, suspicious lesion, and they mention it's from mammography. This is totally wrong concept. This is, a wrong statement. So mammography doesn't cause malignancy. So based on the ultrasound, going back to the lump, so based on the ultrasound, you mentioned that this is highly most likely is a fibroadenoma. Sometimes if it is very small, especially at young age group, you don't want to make scars as long as the patient is asymptomatic, even if it is causing no symptoms. Otherwise, because this is part of the physiological changes in the breast. Because the breast has ducts, has glands, has fibrous tissue, fibrous band, and all of the, during the monthly, changes, this might be changed as well. So it's very common to see, mobile fibroadenoma at young age group. But if the patient, if you have done an ultrasound and during follow-up, you found that the lump is getting larger and larger, this is an indication of to do surgery and take it out. Okay. If the patient is symptomatic, if the patient has some symptoms, pain, and this is an indication to take it out if it's not controlled based on the analgesia that's been given to the patient. If the patient is suspicious, under stress, thinking all day long about what is this, it might be cancer. So stress, this is one of the indication even to excise the fibroadenoma. Now, once it's confirmed that this is cancer, there is something, and large cancer, you don't go directly and take out the lesion or to do surgery. There is something called neoadjuvant management, like chemotherapy. You give, for example, chemotherapy to downstage the tumor to make it smaller size, and this facilitate the ease of surgery. But it has some, indications for the neoadjuvant, because sometimes neoadjuvant might fail and the malignancy might progress. And it's very important, lastly, it's very important, as you have said, awareness, awareness, awareness. Because early detection of cancer during screening, because screening means that the patient has no symptoms. If you detect tumors in early stages, has very excellent prognosis. And you might save the patient of doing, like, based on the mammogram annually done for somebody who is over 40 or 45. And if you see like a microcalcification suspicious, you might do like excision of that mass, rather to do like modified radical mastectomy. That means you are removing the whole breast with lymph node dissection, or sometimes palliative surgery. Because there is something called salvage breast or a salvage mastectomy. That means that the whole breast is ulcerated and with infections and cases of advanced tumor. So prevention is better than cure. Awareness, awareness, awareness. Thank you.
Thank you, Dr. Mahdi. I think you shed light on very informative information. I don't think I can explain after you, but thank you, Doctor.
You're welcome.
Assalamu alaikum.
Walaikum salam.
Yes, first of all, thank you, Ruba, for this nice presentation. I'm Dr. Abdurrahman. Just I have a question. Hi, thank you for a great presentation. Yes, I would like to ask if there is a link between the cosmetic materials and creams and deodorants with the breast cancer.
Well, I haven't seen any, I haven't looked into studies, but as I've heard and I've read before, that it can irritate the area and cause the cancer cells to be aggravated. But I'm not really sure. I don't have any studies to back me up. Well, would you like to inform us, Dr. Abdurrahman?
No, maybe Dr. Munir or our senior professor Alam give us some information regarding this. Is the scientific base regarding the relation between the cosmetic, because it's common use, the cosmetic, shampoos, and deodorants, creams, and so on.
Oh. It could be, well, but I really don't have any much information, unfortunately.
What is the, sorry, can you repeat the question, please?
Yes, Prof. Alam, how are you?
Thank you.
Yes, I would like to ask if there is a link between the deodorants and cosmetic materials like shampoos or creams with the breast cancer.
I haven't come across any paper regarding use of cosmetic or with the breast cancer. No, I'm not aware of any relationship. Diet has got some, but about the cosmetics, I don't know.
Thank you.
Thank you.
Thank you, Dr. Abdurrahman. Does anyone have any questions or points to point out? Or we can end our webinar today. All right, it seems like no one has any questions. Thank you, Dr. Dr. Abdurrahman, Dr. Nasreen, and all the other doctors that gave us the information and cleared it out. And you guys all added a very important value to the webinar. And I hope we see you guys in future webinars. Thank you.
Thank you very much.
Thank you.
Thank you, Doctor.
Thank you. Thank you for all.
Thank you, Dr. Abdul, for giving us the opportunity.
Yes. So thank you all. I will send the recording to the group leaders, okay?